Good morning, friends, and thank you, Dr. Yogesh Bhai. We all understand that even though these are kind of biological substances, we have started calling them devices. And why? That is because they have become indispensable in the prevention of damage to ocular tissues, and they have been given the status of multi-purpose tools. Especially with the advent of phacoemulsification, where most of the surgery is done inside the eye, we really need to protect the tissues. And that's why they have become an integral part of our surgical tools. We can use these OVDs to separate and join tissues, to maintain spaces, to divide into ocular structures, and of course the most important is to protect them. And hence they have been nicknamed as handheld tools. The two main divisions in this viscoelastics are the cohesive and the dispersive, and I would just like to dwell upon them for you to actually understand when and where and how to use them. Right? The cohesive viscoelastics, these are the long chain viscoelastic devices having a property which makes them behave like a long chain and entangle together. Because of this high entanglement, the substance moves together as a mass. Right? And I will just show you in an animation of how that is done. So imagine the green is the cohesive viscoelastic and this is the endothelium. And it has been applied in the antechamber. Now when you try to aspirate or whenever there is any movement occurs, this viscoelastic which is cohesive moves as en masse, and that's why it does not remain long in the chamber. Against that, the dispersives, they are the short chains, they do not entangle, and because of that the molecules remain separated and they move in an independent manner. And a small animation to show that. This is the endothelium, the blue is dispersive and the green is cohesive. Just try to remind that. And that's why they are difficult to remove from the chamber. We are going to use all these properties in our surgery so that we can have a good outcome in various situations, and I'll show you some videos about that also. So these physiochemical properties which determine whether it's a cohesive or dispersive are the molecular weight, the viscosity, the pseudoplasticity, the elasticity, the surface tension, and the molecular charge. I'll not go into a lot of details, but the biggest, the number which separates cohesive versus dispersive is the 1 million Dalton. That is the molecular weight more than 1 million is cohesive and less than 1 million is dispersive. I'll show you one very nice, so in summary, the cohesives are high molecular weight, they are entangled chains, they have high elasticity, they have high viscosity at low shear rates, and they have high surface tension. While that's why they are used for CCC of mature and pediatric cataracts, where there's a lot of raised ICT, the intralenticular tension. They can be used for IOL implantation to enlarge the pupils. Because of their weight, they actually dilate the pupil, and to dissect the adhesions. But the disadvantages are that it has got very poor coatability, like I showed you in the animation. So they come out of the chamber even with the slightest of turbulence, and you can understand the moment your phacoprobe goes and irrigation starts, the viscoelastic starts running away. While the dispersives, they are low molecular weight, they have shorter chains, they have medium viscosity, and they have a low surface tension, and so they remain in the chamber for a longer time. So because of this, they stay longest in the antechamber, but the flip side is they're a bit difficult to inject and require a larger bore cannula, and the other thing is they are a bit difficult to remove also, so you need to spend a bit more time to actually take them out of the chamber, as I showed in the video. Okay, something very important Dr. Shiv Ashrinov gave all of us was the softshell technique, which is usually used in dense cataracts, in compromised endotheliums, iris prolapse, posterior capsule rupture, and subluxated cataracts. And I'll show you a couple of animations to support them. Okay, so this is a patient where you have already had a PCR. So what are you going to do is, to push this and plug this, you're going to use a dispersive viscoelastic, the blue one, right? Because this stays longer. So this is not going to run out once you start your phacoemulsification. So once you plug this, use a cohesive which is a higher molecular weight, fill up the chamber, and this high molecular weight substance will actually push back the posterior capsule. You keep doing the phacoemulsification, but the dispersive viscoelastic will keep the posterior capsule rupture plugged. And that is how you can actually keep this posterior capsule taut. Imagine that this was a capsular hole, but if there was a floppy iris or anything like this, or if you see that the bag is also very lax or there is a zonular dehiscence, I'll show you one more which can lead to other problems. I'll show another cap. So this is how you can use both these viscoelastics, the dispersive and the cohesive ones, to actually help yourself. This is a case of zonular disinsertion. So what is going to happen is, there is all the chance that this area is a weak area. Either vitreous can come out or this area can be caught in the aspiration of the probe, either irrigation or phacoemulsification. Again the same principle, plug this area with a dispersive one which stays longer. Use a cohesive, or even the routine HPMC can be used if you do not want to use a cohesive, pure cohesive ones. Finish your procedure and then actually remove this. Similar animation for how you can do it for a frayed iris. Just in case by mistake you have caught the iris in your phaco probe and this has led to disinsertion of some fibers. Now these fibers, they keep coming to a phaco probe. So what are you going to do is, again the same principle, you are going to plug this area. So you are going to use the dispersive one, the blue viscoelastic, the one which coats and stays there longer, right? And complete the procedure, and your iris tissue which was coming to the phaco probe will stay there, and you will prevent any further damage. So this is how these viscoelastics, they work in the soft shell technique. The second way of doing this is protecting the endothelium. You use a dispersive viscoelastic against the endothelium and the cohesive one over here, and then do the phacoemulsification. This dispersive viscoelastic will protect your endothelium for a longer time. Yes, this was a small study that we did with Dr. Vasavda. Was the removal for each viscoelastic. Elon takes only 20 seconds because it is a cohesive one. It comes as en masse. Elon GB takes slightly longer, while viscot it takes about a minute in spite of an of a continuous or a mechanical automated irrigation aspiration, and it can take up to 2 minutes if you actually want to do a thorough job also behind the IOL. So this is in a nutshell about the viscoelastics. What could be an ideal viscoelastic to help you in your surgeries? It should be transparent, it should be water soluble, it should be easily injected and removed, it should be able to separate tissues gently, keep the spaces formed, protect the tissue, have a pH, osmolarity and chemical features which are ideal to the eye. It should not be allergenic, it should not cause any inflammatory reaction, it should not undergo any chemical or physical change while inside the eye, and no other ocular hydrodynamics can be changed because of this viscoelastic. Well, the most suited viscoelastic is, of course, our vitreous. Otherwise, there is no OVD which fulfills all the criteria. Thank you very much.